I've been an occupational therapist for over 25 years. I've been with Total Education Solutions for the past 13 years. My passion is working with children, and that's been my main focus. I'm certified in SOS feeding therapy, and I also am certified in Cuevas medic exercises.
Very, very interesting. And please go ahead, Stephanie.
Hi, I'm Stephanie Allor. I have been in the field for almost 9 years now, and then I've been with Total Education Solutions for almost 9 years as well. Excuse me, I'm the lead board certified behavior analyst at Total Education Solutions. I work with all ages. I've worked with as young as 2 to um, 21, so I've seen a whole range of kids. And I also we service a school side as well. So I work on that side too in the schools. And I've worked in homes, in the clinic and communities, helping kids gain skills in those areas and be more independent.
Great. Thank you so much for both of you for joining us. I think we're really looking forward to this conversation. Um, y- yeah, Bill, I don't know, should we?
Yeah, I'm Bill Bloom. I'm a licensed psychologist, and I've been involved in diagnosis and evaluation of children for autism for probably close to 20 years. 15 of those years, I was on a diagnostic team at Corewell Health in Dearborn, and I've also been part of a multidisciplinary evaluation team at the Judson Center in Royal Oak. So I look forward to this discussion.
For sure. Thanks, Bill. And then I'm Anton
Yeah.
Babushkin. I run Start My Wellness. We're a mental health company based in Ferndale, and we typically work with all kinds of conditions in terms of anxiety, depression. Uh, we offer medication, therapy, psychological assessment. My direct work as a clinician, as a therapist myself, has not been with autism so much, or myself, but I know a lot of patients that I see. Sometimes they have a family member that they, or maybe themselves, or a family member that needs an assessment. So I'm really looking forward to learning more about the work that you do, and really helping to hopefully answer some questions for people in our community. Um, so, Bill, I don't know. Maybe I know we have some questions on it. Maybe you feel free to start us off.
Yeah, so I think the basic question is, what is autism? I think that's probably where we should begin. And autism isn't just one thing. It's a group of related disorders that have some things in common. But the saying goes in the autism field is, if you know a child with autism, you know one child with autism, because the diversity of experiences for kids on the autism spectrum is just so wide that there's a lot of individual differences. But if we ask the general question, what is autism? It's a neurodevelopmental disorder, which means theoretically, it begins very early in development. It's not something that typically develops in middle childhood, late childhood, adulthood. It's something that develops very early in a child's development. Now, it might not be recognized that early, but if in retrospect, sometimes you go back and look at a child's development and you say, oh, yeah, that could have been a marker for autism that you might not have known at the time. And autism is, in one way or another, it involves in atypical development in the areas of language, social interactions, the emergence of repetitive behaviors, high interest areas, some stereotypical behaviors, which means perhaps hand flapping would be an example of that, but it doesn't occur in all children with autism, so you have to kind of be careful about that. So we're talking about a collection of disorders that are related by some common themes, but there are a lot of individual differences from child to child.
That makes a lot of sense. But what about from kind of your work, Amy, Stephanie? Um, how what might you say? How would you describe some kind of conditions of autism, or what do you see? How does that? How did you get involved in that kind of work? How does it kind of take place in your setting?
You want
You want me
to?
to go ahead?
Yeah, go
Oh,
ahead.
okay. I think Dr. Bloom did a beautiful job at explaining autism in general. And then, like he said, when you meet one person with autism, you meet one person with autism. It's very different across the board. Each child or adult is different. And how we approach the situation is different. It's dependent on the family and where skill deficits are, or the goals that the family comes up with, or even the person themselves. If they are able to contribute to their treatment plan, we ask them questions. But as far as what we do in applied behavior analysis, or ABA, it's the science of behavior, and ABA helps us understand why behaviors are happening, and it helps us teach skills that matter to the person and their family. So we can teach skills like communication and independence and social interactions. And it's really valuable for not only the individual, but the family as well, because we're focused on making daily life easier and helping the person be more independent.
It, so because part of the idea, if I understand it correctly, is that um, the goal with applied behavioral analysis is we're not gonna, there's no changing, or there's no need to, there's no changing the autism functioning of the person, right? The person who has this neurodevelopmental, they function somewhat differently. Um, the goal is to help learn and understand how to help them kind of navigate the world, right? That's part of the idea, I think, that you're describing, Stephanie, is that okay, they may perceive or experience relationships or the world somewhat differently than somebody who's not on the autistic spectrum, but we still, of course, want the person to have a high quality of life,
Mm-hmm.
take care of themselves to whatever degree possible, right? And so the goal of the ABA therapy is to understand that individual in their context, like maybe their family structure, their individual strengths and vulnerabilities, right? And then try to help them or work to help them learn skills to navigate their life. Is that kind of the idea?
Yeah, absolutely. And we take cultural values into consideration too. We meet the family where they're at and the individual where they're at, and we build upon that. We definitely play into the individual's strengths and help them thrive in that way. So, yes, we're definitely taking that approach.
Well, I would kind of just to take one step back, I would guess that it makes sense that sort of the diagnostic part of determining exactly what the person's kind of functioning is so important, right? We'd have to kind of really know, like what are their, how do they function? If it's a kind of a cluster of various neurodivergent functioning in the world, like we have to, right? So I wonder if you could say,
Well,
Bill, maybe you can
yeah,
speak to this more.
well, to speak to that, I mean, the way that we conduct autism evaluations here at Start My Wellness is taking into consideration that very thing that you're talking about, and that has to do with the comprehensive nature of autism and how it affects the person, the child, because it could affect things like language development or motor coordination, certainly sensory processing kinds of things, educational kind of things, abilities to acquire knowledge about the world and express themselves and control their bodies, for example, and regulate themselves. So it for each individual child, it could involve so many different aspects
Hmm.
of their development that we here and most people in the autism field take a very comprehensive global view of the child and don't focus too much on just one thing. And I think that really serves the treatment needs of the kids.
Mhm.
That makes sense. It's like a very individualized kind of treatment plan, so to speak.
Right. Right. So Amy, for example, is a trained occupational therapist, which is an extremely important part of the treatment team. We don't have a speech and language therapist here today, but that would be another person who's a very important part of the treatment team. Certainly a developmental pediatrician or a psychiatrist or a nurse practitioner. So the comprehensive nature of evaluation and treatment of children with autism is extremely important.
And you're basing, when you're doing the assessment, you're kind of looking at some degree of what is it a comparison of what would maybe a neurotypical child, for instance, do at a certain age, and how does the child that's undergoing the assessment, how they function? Is that part of the kind of construct of how to understand the assessment? Kind of like what would be a typical development, and where's the child compared to where they kind of how they function?
Well, maybe Amy or Stephanie can address how they do their initial assessments with these kids.
For sure.
See what yeah.
Yeah, what I was going to say is for occupational therapy, diagnosis is important, but it's really because, like you said, how varied the symptoms may be or what they're dealing with may be. It's really about bringing that child in and seeing how they function in all the different tasks that we may have them try, and base our treatment on that. So it's kind of like a fresh page every time you start an evaluation with someone. It's looking at them with a fresh set of eyes, but a lot of our tests are standardized. So yes, they do have norms that are based on neurotypical behavior or neurotypical development. But that to me is not as important as a lot of the subjective findings that I have as we go along, like attention span, how long can we sit at the table? What is that need going to look like once they start school, and how can we help them foster that and develop that skill of being able to sit for a certain amount of time in order to get instruction in the school. So
That's really
yeah.
interesting. Thank you, Amy. I wonder if you, could you say maybe a little bit more about, can you give any examples? Like, okay, let's say the example you said about sitting at a desk or paying attention. What is the skill development or practice? What does it look like? Like okay, you get to know the child or the individual. You could see that part of their difficulty is with, I don't know, sitting still maybe, or kind of paying attention, right? What
Mhm.
what happens next? I mean, because I think we're talking about how does this kind of, what are some of the principles of this kind of treatment approach, and also what it looks like in practice, so that for the
Yeah.
parent or family member, they can kind of know, like, kind of what to expect, or how does it unfold, or what does kind of progress look like, so to speak, right? So can you speak to, I think you mentioned some really interesting kind of things that you might see in your data, and Stephanie, of course, for you as well, but you mentioned some things that you would see in your day-to-day role. Can you speak a little bit more to what do you notice? How do you intervene? Kind of what are some of the steps involved? What does it look like in practice?
What is
Yeah,
ADA?
yeah.
Right.
Yeah.
Absolutely. So a lot of times we look at, again, we're working with children, so a lot of this is play-based, right? So we're working, we may be wanting to work towards handwriting skills, for example, but we're going to start out with some very fun activities. We might be tracing letters in shaving cream or in kinetic sand, or forming letters with putty and then tracing them with our finger. So that we're going to involve as many senses as we can to keep it very fun and engaging for them. And then two, and this is the part that might overlap with ABA, but also setting goals for, okay, we can attend for 2 minutes doing a preferred activity, but only 20 seconds with a non-preferred activity. So what kind of rewards or kind of steps can we put in there to build that attention for non-preferred activities? Steph, you might want to expound on that a little bit.
maybe we could, excuse me for interrupting, but maybe we could start because maybe some of our viewers don't even know what ABA therapy stands for or what it is. So let's make sure everybody, we have a common understanding of what ABA is. Stephanie, can you address that for us?
Yeah. As I mentioned, it's applied behavior analysis. So we are looking at the science of behavior. Um, in with ABA, we determine why behaviors are happening, what skills we can increase, how we can replace those behaviors with more appropriate behaviors, like maybe instead of screaming, we ask for what we want, or we use pictures to communicate. So we are implementing these principles of ABA and helping the child gain skills, and we're looking at reducing any maladaptive behaviors they may be displaying. And within our therapy, it's a lot of engagement between a technician and the child. We have a lot of opportunities to work at the table, but also a lot of opportunities to explore the environment. And like Amy said, it's all dependent on the child. Maybe they need more play-based, maybe they need more structured teaching. Maybe it's both. So our therapy sessions are all individualized for the child.
Great. Okay, Stephanie, can you talk about the role of reinforcement in ABA?
Yes. Absolutely. So, ABA uses a lot of positive reinforcement. And what that means is we are rewarding desired behaviors and skills. But that reward has to be meaningful for the child. If it's not reinforcement. So, maybe that's a favorite toy, or it could even be physical interaction, tickles, high fives. It can be praise. Way to go. You did awesome. Depending on what the child likes, we're going to use that to motivate them to perform the skill, or to use a replacement behavior like communicating rather than screaming. So our field is filled with it. It's how we work on gaining skills. Every time a child does something that we would like to see more of, we can provide that positive reinforcement. And like I said, it doesn't have to be a treat or a toy. It can be as simple as give me a high five, or or if they like walks, we can take a break and do walking around the clinic, or whatever the case may be for them.
You talked about reinforcement, and it's a very positive type of reinforcement. The opposite of positive reinforcement is punishment or negative reinforcement. Those are different things, but is there a role for that in ABA? I don't necessarily know of any, but I think it's more positive based, correct?
Yes,
There's no punishment. You don't punish kids.
Well, punishment in ABA means decreasing behavior. So
Okay.
it does not mean the same as like when
Right.
when you say punishment, people usually go to like spankings or timeout,
Okay.
or those things. Spankings are in the past, but that's where your mind goes, is something punishing. But in ABA, it just means decreasing behavior. There's a time and a place for it, but we don't typically use punishment. We use a
Right.
lot of reinforcement.
Right.
We have to exhaust all measures of reinforcement first before even thinking about implementing something with the punishment aspect. But negative reinforcement means we are removing something aversive. So it's not always punishing. So taking a break from work, that's negative reinforcement because we're done with work. Or when you get in the car every morning, you put on your seatbelt so you avoid that dinging sound all the way to work. That is negative reinforcement as well. So that one
So in
is
AB,
different.
I'm sorry. I'm
Go
sorry
ahead.
for interrupting. So children in ABA therapy don't experience any negative behaviors directed towards them. It's all
No, they do not.
positive.
Yes.
Okay. Okay. So parents don't have to worry about that.
No. Yes. It's all, it's when we say what we do, we go to work, we play. that's what I do for a living. We play with our kids, we make it enjoyable. We want it to be fun. If it's not fun, they're not going to want to work with us. They're not even
Right.
going to want to be near us. So a lot of what we do is building our relationships with the kids. And like I said, we need to meet them where they're at. And if they're not having a good day, that's okay. We focus on other things. We have bad days too. So, and sometimes we need a break or nap or whatever the case may be. We just need to take a breath. So,
Right.
we need to meet the kids where they are.
And it seems like one of the core ideas is kind of there's like a learning process. The goal is partially to help the child to sort of learn in a way which behaviors are more adaptive and more helpful or more kind of conducive to functioning in the classroom or with their family or in society, right? And which ones are not as helpful, and to try to reduce the not helpful ones and increase the more helpful ones, right? That's kind of one of the core principles?
Yeah, absolutely. We want our kids or adults on the spectrum to be able to access as much of their environment as possible. And if they're engaging in behaviors that, like maybe aggression, they're not going to be able to access many parts of their environment because they could hurt themselves or others. And so it's all about being able to get them to a place where they are able to access as much of their environment as possible.
Kind of like make use of the resources around them, live like a high quality of life, so to speak, right? Is
Yeah,
that what you mean by
absolutely.
accessing their environment?
Hmm.
Now, one question I think about is, this is like when I work as a therapist with somebody who's not on the spectrum, there's also kind of a real learning process. But when you're working with somebody in ABA therapy, are to what degree is the child or the adult, how do they understand what they're learning? Do they understand it more from, oh, this thing gives me a reward, so I'm going to do more of it? Or do they kind of see like, oh, that behavior is more adaptive? Like, what's the level? I don't know if, can you speak to the level of, I'm sure it's different for every person, but how does the child or adult process they're having a good experience with you, they have a good relationship, you're helping them to reduce the not so helpful behaviors, increase the helpful ones, but to what degree do you think the person kind of, what's their understanding of why the good behaviors are good, why the bad behaviors are bad? You know what I mean?
Hmm.
Before we hear from Stephanie or Amy, I wonder if as a psychologist, I could respond to that, how
Sure.
I look at that question, which is a very good question. And the way I understand that question is it's related to the child's level of language development. I would say that children who have more advanced language skills have a better understanding of the bigger picture in terms of what they're learning, and how they're learning it and why they're learning it. Children or adults with less language skills will never really know their level of understanding because they
Hmm.
can't communicate it. Um, but it's related to, I think, the level of understanding of language and their cognitive ability. So those are two variables that are very impactful in terms of answering your question. So now I'm curious what Amy and Stephanie, how they would respond to that question.
I definitely think communication plays a part, because those that have more communication skills are able to access more of their wants and needs. But that's our job in ABA or in speech or across um, disciplines is to um, help kids find a way to access their wants and needs through communication. I always say all behavior is a form of communication. So if they are engaging in aggression or as far as like little kids go, tantrums, they're communicating something. So we need to give them a way to communicate so everyone understands, whether that's through um pictures or a device like a they're called AAC devices, or through verbal communication. So when we give them a way to communicate, the behaviors decrease in and of itself. But um, it is also, I think the positive reinforcement plays a huge factor here, because they do learn that when I do X, Y, and Z, I get ABC. So when I ask for what I want, I get it immediately. But if I'm engaging in tantrums, that is delayed because we're engaging in behaviors, and we don't want to reinforce that. So they are understanding of that reinforcement piece too.
I think, Amy, you kind of hinted at this. Were you going to say something? Go ahead.
No, I was just going to agree with Steph. I think there's a big understanding of that cause and effect. And also, we have a lot of nonverbal kids that once they do get their AAC, it's amazing to see how quickly they start to get language skills. And then also, you can tell a lot from their receptive. So if you ask a child who's nonverbal to go throw this in the garbage bin or whatever, and they go and do it, you know they're understanding you. It's just they're having a hard time communicating with you. And as Steph said, we try all different methods to help them communicate their needs to us.
And to just clarify, an AAC device is what?
It's
So our audience knows.
Yeah, it's augmentative assistive communication, and it's usually like an iPad with a specialized program on it with icons that they can touch, open or close or please or go or yes, no. There's all different words on there so that they can communicate with the people that they're around. Some are much more advanced, some are very simple, depending on the level of the child.
So even children or people who cannot speak can communicate.
Exactly.
Many of them can communicate with an AAC device.
Through the device,
and that would be part of autism treatment, I assume.
Yeah, if needed.
Okay, if needed, right.
Yeah.
Okay, great.
I think we're kind of talking about this already, but what are some of the barriers that kids or adults face who are on the autistic spectrum? Because I think we're talking about a lot of very helpful interventions, communication, interaction, helpful coping skills, so to speak, right? You're talking, I think, a lot about this kind of learning through a helpful relationship, learning all kinds of good, helpful coping skills and communication skills that somebody could use to kind of succeed in their environment. But what barriers do you try to address when you work as a ABA, when you're working as a clinician in your work? What do you see? What are some of the common things that kids or adults face? Some of the difficulties they face?
I would say behaviors are our biggest barrier. Depending on the age of the person, there's a lot of history there, as a lot of learning history that, I've been able to act this way and get what I want, or I've been able to communicate in certain ways and get what I want. So sometimes there's a lot of history there that we have to work through. But those barriers limit access to those other environments, like I was mentioning before. And when we are able to reduce those and give them a means of communication, they're able to access more of their wants and needs, more people, activities, the community. So I would say probably barriers are the biggest. And then depending on their communication, that's also a barrier that we have to work through and make sure that they have a way of communicating.
Sure.
I would also add to that parent training is a huge part of what we do. And we only see the child for OT, PT, or speech only for an hour, maybe once a week, maybe twice a week. So especially if I'm working on feeding therapy, which has a lot of similarities with ABA, if I'm not engaging in parent education and really teaching the parents how they should present foods at home and things like that, they are not going to, they're not going to progress as fast because they spend all that rest of the time at home with mom and dad. So the techniques that we're using in our sessions are not helpful unless they're being carried over at home. And sometimes sometimes we have to work through with parents that a little bit of resistance. And again, I'm talking about the feeding therapy part of it, because nobody wants to see their child go to bed hungry. So if I'm saying, don't prepare a separate meal for them, offer them what the rest of the family's having, and they're like, yeah, but they're not going to eat, So I need their buy-in to really understand why we're doing what we're doing and how that child will progress for going forward with that.
Amy, I have a question. That was a great explanation. I want to go back a step. Kids are frequently picky eaters, picky. Some adults are picky eaters. What kind of child, or what do you see in children who actually would benefit from feeding therapy? What is feeding therapy, and who benefits from that?
Sure. So there is kind of a standard that in the SOS feeding that I do, that they say if there's 25 foods or less, that is a problem feeder. If you have more than 25 foods that you'll eat, then you're just maybe a picky eater. But within that 25 foods, it could be you'll eat Cheez-Its, you'll eat saltine crackers, you'll eat Ritz crackers. So those are 3 foods right there, because our really, really restricted kids, they'll only eat goldfish crackers and they have to be this particular shape and this particular color, or they'll only eat McDonald's chicken nuggets. And if you try to make them homemade chicken nuggets or frozen chicken nuggets, they won't eat them. They're different shapes, they're different colors, they're different consistencies. So the ones that are really, really restricted would benefit from feeding therapy. And what we do is there's 2 types of meals. There's a family meal where it's served family style. You pass the food around, you take a little pasta on your plate, you take a little of the beans, you take a little bit of the carrots, whatever's coming across, and you're exposing that child to all those foods. In a family meal, you're also going to provide their preferred food, because you want them to participate in the atmosphere of eating together. A therapy meal, we're not so worried about the quantity, how much they eat. We just want to try to increase how the different types of foods they'll eat. So what we'll do is we'll pair foods closely together. So if they'll eat a McDonald's chicken nugget, we might add in a nugget that's very similar to it, or a different kind of chicken, and we'll talk about the similarities and the differences. And again, depending on the level of the child. But with our older kids, we talk a lot about kind of the science of things, how crunchy things are, how they sound, how they look, how similar they are. And we play with our food if they're younger, a lot of play-based. And by just that exposure, we're slowly getting it closer and closer to their mouth, and to the point that they'll eat it. It is not force feeding at all. Because when kids are force fed, or we're bribing them, and it becomes a very highly anxious thing. And when your anxiety is up, if you're running away from a tiger because your anxiety is so high, you're not thinking about your next meal. So same with kids, if their anxiety is high, their appetite goes down. So
yeah, that's a great explanation. It helped me understand it as well. I never really asked an occupational therapist about that before, so I appreciate the answer. This is for kids whose autism interferes with their feeding, it sounds like.
Yeah.
And it's not for kids who might have like swallowing difficulties or motor difficulties. That is a different kind of feeding therapy, and that would be done by a different type of therapist, I'm assuming.
Yeah, and usually in that case, it's done with a team, like a speech therapist, but they also have to have the swallow study done ahead of
Correct.
time. But there
That's
could be a
good.
speech therapist
Okay.
and an occupational therapist on the team, but
Right.
usually a nutritionist, a doctor, it's going to be
Got it.
more involved of like getting them off the feeding tube.
Got it.
A lot of SOS is basically dealing with those different textures, the
Mhm.
sensory input of
Got it.
eating. Mm-hmm.
Thank you. Yeah,
Yeah,
great. Thank
absolutely.
you.
We have a question here from the audience, which is the audience person said sometimes kids who maybe have ADHD, not necessarily on the autism spectrum, also maybe struggle with some of these related type behaviors or difficulties. Um, I don't know if you, Amy or Stephanie, if you, maybe that's not your focus necessarily, but I'm guessing that there are similar treatments. It's not only for necessarily a child on the autism spectrum, but maybe a child who struggles with whether it's eating or these behaviors. Let's say a child who has ADHD. I think there are probably treatments for that as like for those kids as well, right?
Yeah. So with OT, like I was saying before, the
Yeah.
diagnosis is important, but it's really what are we seeing? Where are the deficits? How is it affecting function? That's where I'm going to focus on more. And sometimes it's comorbid. Sometimes they have autism and ADHD.
I see.
So, but we as OTs, we're going to look at that sensory function. Are there sensory inputs that are causing that difficulty with time, with attention? But we're also going to focus on executive function skills with them and teaching, depending again on their level, time management and organization and all of that kind of thing. So OT can focus in that regard on ADHD.
Stephanie, what about? Go ahead, Bill.
Oh, Stephanie, did you have anything to add? I have a follow-up question.
Yeah, just as Amy said, a lot of our individuals can have comorbidities. So ADHD is a big one with autism. But in the field of ABA, right now, autism is the primary diagnosis that we serve. Um, but ABA can be used everywhere and with many different people, even, people without a diagnosis. It benefits. I use ABA at home with my animals. And so it can be used for a variety of different areas. It's not just for autism, but that's where we are at right now. My
And
hope is that as the field grows and continues to um, in enter different areas, we'll be able to see more ABA in different areas.
And
see.
that's
Yeah.
due to payer,
Yes.
the insurance companies will only reimburse for ABA if the diagnosis is autism.
Mhm.
That's true.
That we choose not to work with them. Yeah.
Yeah.
Yeah. Yeah, it's
Which
not our choice.
Yeah,
Mhm.
right. Which leads to my next question, which is one of the features of ABA that helps it work is the intensity of service that the children receive. So when parents get a recent diagnosis or a new diagnosis for their child with autism, and they are referred to your ABA center or some other ABA center, what could the parents expect? What is out there that they should, oh, this is what we're doing. This is why we refer there. What is the process of ABA?
As we get started, parents usually reach out to us, interested in services, and we always start with an assessment and a conversation with the parents as far as, what are the goals you would like to work on? What areas for behavior decrease do you want to work on? And like I mentioned before, if the person who we are looking to give treatment to is able to speak on their behalf, we can get their input as well. What goals are you focused on? Where would you like to grow? And then we can move from there. The assessment that we pick is all dependent on their skills and age. So we always gather that information from parents too, like just basic questions like where their communication is at and depending on their age, do they sit at a desk at school? What are their strengths at school as far as do they transition well from class to class, or even at home, do they transition well? Um, and some of those areas help us decide what assessment we're going to use. And then from there, we create goals and we write a report, and then we get started with our sessions. As far as the hours go, it is all dependent on the client and those skill deficits, like how much we will need to work on. Um, I will say that that intensive 40-hour-a-week therapy is sometimes necessary, but it is a thing of the past. A lot of insurance companies and clinics are moving away from that. It's a long time for a kid um, to be in therapy for. It's more than school. Sometimes school is about 35 hours a week. So the hours are all dependent on what works for the family, and then what the assessment says as well.
What would be the range of hours that you would want to see a child? Like just a range. I know that you can't pin it down to any individual child, but
Hmm.
what is the range of hours that you typically see kids in ABA therapy?
Anywhere from I would say 15 to 30 hours. There
Okay.
are kids that do less because they're in school. So like our evening sessions are 12.5 hours. But I would say between that range is standard.
Okay.
That's like total hours or per week, do you mean? Or is that like,
It's per week. Yep.
I
Per
see.
week.
Yeah.
So they're kind of
So
very, go ahead.
it requires a big commitment for
It does.
families, and sometimes it requires the families to really make adjustments in their own personal schedules and how they, the challenge for families is how to accommodate that level of treatment, which is necessary into the overall functioning of the family. It's sometimes a real challenge for families to do that. And we have to be mindful of that and helpful to families when we can be.
Yeah, absolutely.
I know you, Amy, you and Stephanie touched on this a bit, but can you say maybe just a little bit more about how the parents participate? Like, what, yeah, the role, I understand the idea of their role makes sense. The things that you practice with the child and that, you work on, you want, ideally, the parents are also kind of learning that whole process and applying the same ideas, ABA sort of ideas at home, right, or wherever they are. How does that work? How do the parents get involved? How do they participate? And then, what's kind of the progression there? Is it kind of gradually they learn the skills and they're also kind of applying that kind of same methodology at home? Like what's the process like?
Yeah, parents are essential to our therapy, because like Amy mentioned earlier, if they're not doing it at home, those skills are not transitioning. So, all of the work that we're putting in therapy is not going to transfer over to other environments or even to other people. So, parents
Hmm.
play an essential part in our treatment, and we do what we call parent training. It's parent coaching, and we help parents implement what we are implementing at the clinic, or we do in-home therapy as well. So even in the homes, when we're doing in-home therapy, it's nice for parents because they can sit in on sessions or see those. And that's not to say they can't do that in the clinic setting, but it is easier in the in-home setting. They're already there. So they are able to see what we're doing and participate in our sessions. And but we work with them outside of session too. We set up monthly meetings, sometimes even weekly, bi-weekly meetings, depending on the family's com not commitment, availability, but I guess commitment too. But without their help, we're not able to transition these skills into other environments. And it's going to hinder the client's progress. So they won't be able to make progress in school with these new things that we're teaching them, or in the community. So when we're all on board, we're working together and towards the same goal.
And is this, thank you, is this kind of over, kind of going back to Bill's question about sort of a range? I mean, how long would a child potentially be in this kind of treatment? Is it months, years, ongoing, is it ongoing throughout their life? I'm sure it depends on, different situations, but what do you typically see? I mean, is it maybe they make progress over some months or I guess years, and then they could do it on their own? Like, what does it look like in terms of kind of the gradual progression? Or as the child, gets older or grows up?
Yeah, I will say as the child gets older, therapy tends to decrease. Um, just due to time and we kind of hit a threshold for skills and where we're at with that. But it is all individualized. I will say that it we're looking a lot of the time at years in therapy for ABA. But it's all dependent on the client's progress and where they come in too, as far as like um somebody with that's getting early intervention, so they're starting young, we're able to address these skill deficits and behaviors early. So they may graduate from ABA faster than somebody that may have gotten started later, but it is all dependent on the child and their progress.
And it makes sense. And sometimes, I don't know if it applies in your world, but I know that sometimes when kids are older or they go to, they're young adults, they're 18, they're older than that. Um, is the access or availability of services different for, let's say, an 18-year-old or a 19-year-old? Because we're talking a lot about best case scenario, early detection, right? Early diagnosis. I mean, like I've heard you say before, Bill, that like if the child is 2, you don't want to wait till they're 4 to say, oh, something, their functioning seems somewhat different. You don't want to say, oh, let's just see what happens. You want to try to say, wow, I'm noticing something. The pediatrician or the parent or the teacher,
Right.
somebody's noticing that. So we talk a lot about early intervention. Let's say, best case scenario, that does happen. Um, what happens to, let's say somebody's 18 or older, like how do they access services or how do they kind of make use of this kind of methodology?
It is all dependent on the insurance company. Some insurance companies have a cap as far as age goes. Other insurance companies don't, like Blue Cross Blue Shield. They do not have an age cap, so we can service
I
adults.
see. I see.
But it is more difficult for older children, adults on the spectrum to access services. Um, uh it's a lot of the time due to insurance companies. They want to see certain things on the report. They want to see a certain amount of progress. So it's dependent on what they are going to allow us. But um, uh, as far as who can access, it can be anybody.
Right, because it sounds like the skills and the learning and the principles are sort of like universal, so to speak. They could be useful in a variety of settings for a variety of people. It's part of the question is who's paying for the services
Yeah.
or what their availability is, right? Or how much time they can commit. There was another question from the audience about going back for a minute about the young child. Um, so let's say if the child's attending school, maybe they're in school full time, how many hours might I mean, do kids still participate in like ABA every day, or what might that look like? I guess that depends on the family's availability to access the services too.
Yeah, it does depend on the family's availability. A lot of kids are in multiple therapies, speech, OT, ABA, or they have extracurricular activities like sports or music. So it is all dependent on the availability of the family, but those that are school age, we do see less often. We're not seeing them those 30 hours a week. We're not seeing them a lot of the time during the day. A lot of the time it's after school hours, and
Sure.
that's where that range of maybe 10 to 12 hours comes in. Um, but it could even be less than that depending on the family's availability.
Yeah, it's really interesting. Do you end up working a lot of like late afternoons, evenings? Because if the families are not available, during the day, the kids are I don't know,
Yeah.
the parents are at work, I guess, like how does that work on a practical level? Is it
Yes, we do work a lot of evenings. We have a lot of evening clients. So as far as our clinic goes, we are open until 7. And we do in-home therapy until 7 as well. So, late nights, as far as, that's can be late for a kid. So, that's why we tend to see our younger kids during the day,
Hmm,
because they're not in school. We have more of
I
that
see.
time. And then
I
as
see.
they get older, they move to evening where they can stay up a little bit later and
I
they
see.
have the stamina to do go to school and then, do our therapy as well.
I have a question. We're talking, a lot of the interest is on the younger kids. I'd like to focus a little bit on teens, particularly maybe preteens or teens. Perhaps they've successfully gone through a course of ABA therapy. Their communication has much improved. Their personal regulation has improved. Their friendship patterns may have improved somewhat. But as they get into preteen and teens, their self-care, their activities of daily living, their hygiene, their self-care, their ability to monitor their hygiene and things like that are sort of off and require a lot of parental oversight, supervision, monitoring, encouragement. The goal obviously would be for these kids to be more independent, right? Is ABA appropriate? Can it help in that arena?
Absolutely. When I have new parents coming in for ABA, I tell them that we can work on you name it skills, because we could pretty much do it all. We do potty training, we do showering, dressing, even vocational skills. So we do job training as far as let's practice interviewing, let's apply for places.
Mm.
So as kids get older into those teens and adulthood, we switch gears and we can do more of those daily living skills and even brushing teeth, putting on deodorant, all of that we can work on.
Okay, good.
It's so interesting to hear about how I can imagine that it must be in a sense a real relief, a parent who has a child who was recently diagnosed, with autism or at some point diagnosed. It's got to be so much. I mean, being a parent's challenging anyway, but so much to learn, so many kind of potential challenges, in the young person's life. It must be for parents who have access to this kind of services or these kind of treatments. I can only imagine there must be some sense of some degree of relief or helpfulness, right? To know that some of these behaviors or challenges could be helped. They're not simply unaddressable or unmanageable. You know what I mean? So I'm hoping that for parents who watch this podcast, they many parents might have additional questions. We don't have time to get into everything today, but it seems like a methodology that could be helpful in a variety of different situations, especially because the parents can maybe learn some of these skills for themselves. I'm sure it's hard to do kind of on an everyday basis, but it seems like a very useful kind of set of tools and ideas. Are there anything, just in kind of an interest of time, one part is we would it be okay for somebody who has a question to kind of reach out to you for a follow-up maybe, for something that we haven't covered because we're just kind of, so to speak, scratching the surface of what does this look like, when, how. I'm sure some of our audience may have follow-up questions, so I hope they, you know, I know sometimes Bill, you and I will say like, they can call our office when it comes to like uh, mental health kind of stuff, but I'm guessing that your company works similarly, that people, sometimes people call with questions to try to understand what to do, how to do it, what resources, right? I'm guessing you field a lot of those kind of calls.
Yeah. Yeah,
Yeah.
and I also think that there are many different ABA centers. There's many different places to get autism evaluations. But since we have Stephanie and Amy here with us today, why don't you tell us where you're located?
Yeah.
Sure. So we are in Troy. We're on Crooks Road, right near Maple. And yeah, we would welcome any kind of questions. We give tours of our building and spend time with parents really explaining the program and what we have to offer. And just as kind of an offshoot, I am the program manager there, and that's why I jumped on the call with you guys. Although I was able to share a little bit about OT as well, but we do provide OT, PT, speech, as well as ABA, and a lot of the kids that we service definitely benefit from all of those therapies.
When I do my diagnosis on an autism evaluation, I will stipulate whether or not I believe the child should be at a comprehensive autism center. And the comprehensive part of it has to do with those ancillary services that are offered on site. And there are many great places that offer that, but not every ABA center offers that.
Right.
So that's important to know.
Right. We do interdisciplinary meetings every month on each client that is a shared client. We share our techniques with one another. It's a wonderful collaborative environment. So, and I definitely see the benefit for a lot of children
Great.
to have that type of help, you know.
Yeah.
And speaking to the idea of hope, there is hope. There's a lot of hope. There's a lot that, you know, an initial diagnosis can feel very daunting, but there are a lot of great resources out there, and we're definitely one of those resources, and we'd love to meet you and help navigate that whole you know, journey of how to, you know, get the skills that we need to get.
Sure. That makes sense. Well, thank you so much thank you, Amy and Stephanie and Bill and our audience. We love doing these programs because the information you're sharing is not always easily accessible. People might not know, you know, some of the rich things that we're talking about. So, and we're looking forward to collaborating with, you know, your group and kind of working together on helping families and kids and adults. So just really great to have you on the podcast.
Yeah.
And thank you for your time and your attention. And just we look forward to kind of talking more and helping more people. So
Thank you.
Thank you for having us on.
Yes,
Definitely,
thank you so
definitely.
much.
Talk to you soon.
Okay.
Okay.